Hey, what's up and welcome to World 8 Level 2 of Power Up Endo's 90-Day Super GP. In this level, we're going to discuss complications that you might encounter when performing endodontic treatment. And it's super important to be able to identify these complications if and when they occur, because the way that you respond to those complications, both as the operator and also in terms of the way that the patient perceives this complication, makes all the difference. So I want you to have early identification in identifying when these situations occur, which some of these I almost guarantee will occur at some point. And I want you to be able to manage those situations so that you know what to do. That really makes all the difference. So without further ado, let's get into it. So first is cracked teeth. Cracked teeth are very common, as you know, and they're truly the kryptonite of endodontics. What I need you to understand is that cracked teeth fall into two camps, and these two camps are very different. I know I touched on this earlier in the course, but your vital cases are going to do very differently than your necrotic cases when a crack is the cause of the endodontic problem. Generally speaking, your vital cases are going to do much better than your necrotic cases if you perform endodontic treatments and then you restore the tooth with a crown as opposed to your necrotic cases. The reason for that is because usually your necrotic cases where you have a cracked tooth, the crack is much worse, and it's much later in the process as opposed to your vital cases. Because your vital cases, the crack might be much more superficial, but by the time that the crack has caused pulp necrosis, we're later in the process, and so more bacteria has had a chance to settle in, and the crack is going to be an influx point for future bacteria, oftentimes, assuming the crown doesn't cover the entirety of the crack, which there are many times that it doesn't if we're dealing with a necrotic pulp because the crack is much larger. And in terms of the symptoms, your patients who have a cracked tooth that's causing them problems where the case is vital, they're oftentimes going to complain of pain on release of the chewing cycle. So when you do your bite test with either a cotton roll or a bite stick, they oftentimes will feel a significant zinger on the release action. And your necrotic cases, the symptoms are much more variable. So you can have a patient who has no symptoms, or you can have a patient with significant pain and swelling. So it's more challenging to discover sometimes the necrotic cases, especially when there's a crown on the tooth and you don't fully trust your cold test. So you have to use all the information that you're gathering from your clinical testing along with your radiographic examination to try to decide whether this is the case. The most common situations when a crack is present is going to be your lower posterior teeth, as you already know. And usually it's either virgin lower molars or it's lower molars with a shallow class 1 restoration, usually an old amalgam restoration. So you want to visually discover and visually inspect the tooth so that you can help screen out these cases before you just go ahead and treat them without discovering that we're dealing with a cracked tooth. And like I mentioned earlier in the course as well, if you don't have a deep restoration, you don't have any deep caries, you're looking at a lower posterior tooth, and you either have necrosis or you have signs of an endodontic problem, you got to start thinking that maybe a crack is the cause. And it's important to be able to decide and decipher when that's the case so that you can plan accordingly. A lot of these cases are managed with patient expectations. So as I mentioned earlier, if you set the expectation and you give the patient the opportunity to make an informed decision on what they want to do, that way they're bought in to the eventual outcome, whether it be positive or negative. Cracked teeth present themselves in a whole host of ways. So you can have tiny little craze lines, you can have obviously fractured cusps, you can have your traditional cracked teeth, you can have a crack that eventually leads to a split tooth, and you can have vertical root fractures as well. Vertical root fractures, unfortunately, is a term that's used much too broadly with cracked teeth. So generally speaking, you're only going to find vertical root fractures on your previously treated cases, and the vertical root fracture oftentimes initiates or starts at the apical region and progresses upward. They're not nearly as common as patients might think, because dentists tend to use that term much too broadly. Next, we have calcifications. So obviously calcifications are also very, very common, and you have to be able to identify them because they make your cases exponentially more challenging. I want you to make sure that you're studying very carefully your preoperative bite wing and periapical radiographs so that you can identify when calcifications are present, because you want to, number one, consider either extending the length of the appointment in which the endodontics is going to be performed, or number two, consider referring this patient out because you don't want to be bothered. Number three, potentially considering dental extraction because no one's going to be able to perform endodontic treatment on this case. And number four, also because potentially you want to set the patient's expectation and let them know, hey, we're going to do everything we can to treat this case, but you have to be aware that you have significant calcifications inside your tooth and root canal treatment might actually not be possible. We're going to attempt it and see if it is possible, but I want you to be aware that it might not be possible. That way, it's not a surprise to them if you have to stop the procedure and say, I'm sorry, unfortunately, root canal treatment is not going to be a possible treatment scenario for you, and we need to consider alternatives such as, potentially dental extraction. When you're studying your preoperative radiographs, I want you to be very careful when you look at the pulp chamber area because you want to know if you're going to have a very difficult time locating canal orify. Also, I want you to look at the roots themselves and follow the canal. If you find that the canal abruptly disappears inside of the root, that is oftentimes the case when you have multiple branches potentially splitting off into 2 or 3 sometimes canals inside a root. And you want to be able to identify that as well. Sometimes, and you may not want to do this, but sometimes if I see a calcified case and I'm not sure if it's going to be possible, I will do an exploratory procedure and actually let the patient know that I'm going to invest chair time for them to discover if a root canal is even possible. And again, you want to set the expectations. There are times when we're pleasantly surprised, but if the patient's made aware, it takes away that surprise and it makes a huge difference as to how they respond if root canal treatment is found to not be possible. And the next thing you're going to encounter is complicated anatomy. So I put a list together here of some of the more common situations, and they range in terms of whether it makes root canal treatment significantly more challenging. So lower incisors oftentimes have a second canal. It's not the majority of the time, but it's something that you're going to encounter from time to time. So you want to discover this because you may or may not want to treat these cases. Usually the lingual canal is much more challenging to find than the facial canal, and they're usually in that configuration where you have a buccal or a facial canal superimposed over a lingual canal, and an angled periapical film is going to allow you to discover that there are 2 canals present. Also, lower premolars can sometimes have multiple canals. And like I mentioned earlier in the course, these are notoriously challenging to treat, even for the most experienced endodontists. So, you may or may not want to treat these lower premolars with multiple canals. Also, upper first premolars can have 3 roots. This is something, again, that you want to try to discover preoperatively so you can make a decision whether you want to treat this or not, or whether you want to refer it out, or whatever you want to do. These are also challenging, and you don't want to get into a case, find that you've discovered 2 canals, but they're not lined up in the buccal lingual plane, and then you look at the film, preoperative film again, and you discover, oh yeah, look, it looks like there's a 3rd root, and then you start digging for it, and it can be a nightmare. So again, all these things are really, really nice to discover preoperatively as opposed to intraoperatively. Another situation are lower molars that have a C-shaped canal configuration. So if you see a lower molar that has what appears to be a single root or fused roots, that can sometimes mean that they have a C-shaped canal configuration, where in cross-section, the pulp chamber actually has a C shape as opposed to individual little canals. And these are a little trickier to treat, especially on your necrotic cases, because disinfecting them is slightly more challenging because we have a round instrument in the form of our rotary instruments, right? But the the canal is C-shaped, so it's challenging sometimes to debride and disinfect these awkward shapes. Next are dilacerations. So as you know, dilacerations are a sharp curvature in the root, oftentimes approaching 90 degrees. And these are, again, very challenging to treat because your metal instruments, both your stainless steel hand files and your Nitai rotaries, it's challenging to put that much strain on them and reach the apex consistently. And then while technically complicated and unusual, you also have these lower and upper molars where you have, two and sometimes even one canal. And you're going to love those because obviously that patient is coded as having molar root canal treatment done, but it could be a single canal, which is fantastic. These are the best. All right, so another thing that can happen, as you know, are perforations. So perforations go hand in hand with calcifications. So if you have a lot of calcification present and you're struggling to find the root canal orify, a perforation can very easily occur. So again, this is why I want you to study your preoperative radiographs very, very closely before committing to the case and deciding what you want to do. Perforations can be repaired with either MTA or an MTA-like material. I like Brasseler's Bioceramic Fast Set Putty. It's the same chemistry as the sealer, but it's much, much thicker. It's actually a Cavit consistency, and it's much easier to work with, in my opinion, over MTA. But it's essentially placed right into the site of the perforation and then burnished with a moist cotton pellet or a moist paper point. Early identification of these perforations are critical because what you don't want to do, trust me, I know this from experience, is confuse a perforation site with what you think is just vital pulp tissue that's bleeding. Because what can happen is you're going to irrigate that site with sodium hypochlorite in an attempt to stop so much of the bleeding, not realizing that you're actually putting sodium hypochlorite into the soft tissues and thus setting yourself up for a sodium hypochlorite accident, which we'll discuss shortly. So you want to identify if perforations have occurred. If you think that you're in a canal that is actually a perforation site and you stick your hand file in there and attach your apex locator clip, your electronic apex locator is going to go red immediately. It's not going to be looking for that natural anatomic apex. It's just going to go right to red. And that is when you discover and you smack your forehead, at least mentally, and say, oh God, we're dealing with perforation here. We have to manage that. But you want to discover this early. You don't want to continue to instrument what you think is a canal that's actually a perforation, only to discover late in the procedure that you've been instrumenting this perforation to be a massive hole inside the patient's tooth. Okay, so identification early is critical. And then next is a slightly more common complication, which is your file separations. Now, it shouldn't be very common, obviously, but it does happen from time to time. And there's an old adage, as you already know, if you haven't separated a file, then you're not performing enough endodontics, because it happens to everyone at some point. But it should only happen, 1-2% of the time. It shouldn't be 50% of your cases, right? So if that's the case, you need to really consider going back to the basics and definitely being more careful with your glide path preparation, which, as you already know, is creation of a smooth, reproducible path for your rotary files. I recommend opening up to at least a size 15 hand file before introducing your rotary files. The time in which a file separation happens is very, very important because it really dictates what the long-term prognosis of the case is. So, an example, when a file separation occurs on a vital case, let's say, that's maybe your last rotary that you are putting into the patient's tooth after you've done a significant amount of disinfection, that case will tend to do much, much better than a necrotic case that's significantly infected, where a file separation happens early in the procedure, and thus your disinfection overall is going to be significantly hindered. There's going to be a lot more bacteria that's present that's going to eventually lead to likely failure, as opposed to a vital case or even a necrotic case when it's your last rotary instrument after you've done some thorough disinfection. So there's a lot of variables. Again, this is going to happen eventually, but it should be on rare occasion. And a study done by Iqbal in the Journal of Endodontics actually found that the incidence of file separation over a 4-year period on over 4,800 resident cases, hand files separated 0.25% of the time, rotary files separated 1.68% of the time, again, a very small number, and the apical third was by far the most common site of all file separations. Lower molars were actually the most common tooth type where file separation occurred. And that is probably due to that complex anatomy in the mesial root that I've already discussed with you multiple times throughout the course, where usually the mesiobuccal canal will merge with the mesiolingual canal, and that site after it merges, where you have a common exit, is where a lot of strain is placed on your instruments and is the most frequent site for file separation. And next we have sodium hypochlorite accidents, which is a very rare occurrence, but it can happen, and I want you to be able to identify if this ever happens to you so you know exactly what to do. You already know in the live case demos from my narrations that I keep the irrigation needle very loose inside the canals. So much so that I purposefully jostle the irrigation needle inside of the root canal so that I know that it's not binding and thus squirting irrigation solution into the periapical tissues. So I do that to prevent these situations from occurring. Also, diluting your sodium hypochlorite down, I recommend 50-50 dilution. Diluting it down is going to decrease the chances that you're going to have a sodium hypochlorite accident. If this occurs, your patient is going to immediately start complaining of burning sensations and a lot of pain. And if you discover this is to be the case, you're going to immediately stop irrigating. You're going to have your assistant reach for saline. You're going to draw up saline into your syringe, only saline, and then place an irrigation needle on that and start doing a lot of irrigation with your saline to dilute the sodium hypochlorite in the tissues. You're going to immediately temporize your patient. You're going to prescribe antibiotics. You're going to let them know what's going on. You're going to prescribe some pain medications, whether that be analgesics and or narcotics, and you're going to be really, really diligent about following up with this patient daily for 3 to 5 days. You might even, if it's over the weekend, have them send you pictures. You're going to want to prep this patient to let them know that they're very likely to be experiencing a lot of swelling, a lot of bruising, and a lot of pain. And you want to monitor them very, very closely and consider, if that occurs, especially if the swelling gets out of control, sending them to the oral surgeon. And the Journal of Endodontics published this article where a survey was sent out to all the diplomats of the American Board of Endodontists and asked them, number one, if a sodium hypochlorite accident had occurred in their career, what were some of the factors of the case so that they can be more easily identified? And they discovered that, number one, women were more frequently the patients when this occurred. Number two, maxillary teeth were more frequently the site of this occurring. Number three, posterior teeth were more frequently the location. And number four, necrotic cases with a lesion were the most common situation. And that's likely due to the fact that the periapical bone creates somewhat of a barrier as opposed to a big void in the jawbone that's going to be a potential site where the sodium hypochlorite will seep out and create this problem. Also, all the cases resolved in approximately 1 month, which is a long time, I know, but it didn't technically affect the prognosis of the case. And the diplomats that responded reported that 83% of the time they had used full-strength sodium hypochlorite when this occurred. And this is reason enough, in my opinion, to dilute your sodium hypochlorite down 50-50 in all your cases. Is there a potential loss in the disinfection properties by diluting your sodium hypochlorite? Yes, potentially. But there have also been studies to show that you can overcome this with more volume of irrigating solution. So that's why I advocate for dilution down to 50-50 and increasing your volume. So 10, 20 milliliters are, usually what I will use for most cases, sometimes more. And then next we have flare-ups. Flare-ups are defined as a situation where your patient has pain and or swelling that requires an emergency visit that you didn't plan for. And they're not that common. They only occur about 1.71% of the time, but they can occur. And it's much easier to deal with a patient who has a flare-up when they're between visits. So when they're a 2-visit case and they have calcium hydroxide in the canal, because all that needs to be done in those situations is the temporary filling needs to be removed. You have to do a significant amount of irrigation inside the tooth, and then you have to make the decision whether you want to retemporize or leave the tooth open. As opposed to cases where a 1-visit treatment was performed, because now you have gutta percha in the roots, and that gutta percha has to be removed before you're able to disinfect the tooth again by passing a lot of irrigation solutions through the canals. And then again, deciding whether you want to medicate and close or potentially leave the tooth open. Antibiotics are generally always prescribed for these patients that have a flare-up because it's usually due to a bacterial infection. And that's it. That's the most common complications that might occur if you perform lots of endodontics in your practice, which I encourage you to do. I hope some of these never happen to you, but some of the more common ones, such as separated instruments, cracked teeth, perforations, these things are going to happen. Hopefully not frequently, but they're likely to happen at some point, and the way that you manage them and your early identification of these situations are going to make all the difference. But you have to disclose these kinds of things to your patients, but the way that you present them and the way that you respond to them makes all the difference. And that's why I wanted to make sure to inform you so that you know exactly what to do. All right, enough of that. I'll see you in the next lesson.